major. Patient supine, lumbar spine flat against table. Remember the neurologic patients, because of the hip flexor tightness, usually need to put a bolster under their legs. Okay, so we want lumbar spine flat. Okay, let's get that flat a little bit. I'm going to bring you up even more. Okay, there we go. I want it snug. I can't get a hand under that. Really snug, not like any room in there. Okay, so lumbar spine flat against table. Have it abductor arms 135 degrees. So both arms out. And you really should, we need a bigger table ideally. Elbows should stay on the table, but we can still tell. Slide them out. Okay, he's pretty good. But we're watching to see if he's starting to extend. Keep your rib cage down. I think he looks pretty good. So I would measure this with a goniometer. I think he looks close to 135. Does anybody know if is this how you've measured it before?
That's how I did the sternal fibers.
Okay. And then, so what else have you done? So he gets to 150. Okay, well, we're not going pro. The other way I've seen is hands behind the head, and then elbows resting down. Okay, which are kind of easy. Now, with the neurologic patient, what is feasible for looking at pec major, looking for pec major restrictions? Remember, you've got to keep in mind that we need humeral head and glenoid fossa, which is most likely going to happen in the scapular plane, so about 30 degrees up. They generally cannot go way down here. One reason is that humeral head's already anterior, so if I kind of keep pushing them down to the table, where am I driving that? Further anterior. So don't do that. Keep them elevated towards scapular plane. Then take them up and just see how far you can get. I mean, you're going to feel, it feels like cord or concrete up in here as you start coming up. And just see how far you can get them up and when the elbow really starts pulling inward. Okay? But you are going to keep them about 30 degrees elevated off the table, scapular plane, and then just notice when it really starts to spring up. Okay? And then feel muscle tone the entire time that you're going through there. Okay? That's what's going to be feasible for them. Okay, pec minor. What have you guys learned?
Just push down.
Yeah, just laying supine, right? Just looking to see if spinous scapula sits on table. How have you measured it?
From the acromion.
Fingers?
Yeah.
Yeah, I like fingers. And what's your point where you measure?
Acromion?
Acromion? Yeah, okay, good. So that's what I like. I like taking posterior aspect of acromion and just measuring distance to table or fingers. He's about 3.5 fingers on the right and 4 fingers on the left. Okay? I like to give them the benefit of the doubt and just give them, so not pushing on humeral head, but coming in a little more and give them a nice stretch and just see if they can settle back a little bit. Give them, a chance to stretch back. It's not so strong of a stretch I'm going to necessarily change a lot of range right away, but he is better. It's about 2.5 and 3. Just give them a minute just to settle in and stretch them down a little bit. Yeah, so pec minor, easy, right? So those are the things you will definitely be assessing on them for restriction, for feeling, for muscle tone. Now again, the advantage of the hemiplegic patients, you've got an intact and an uninvolved side. So you can just feel the different portions of the muscle belly on one side versus the other and notice the difference in the tone. So the squishiness, right? How hard is it when you push down on it? You can say hypertonic on the right side. Pec minor is way down under there, and we're going to dig into that in a minute. We can't really palpate pec minor very well through pec major because it's such a thick muscle. Okay, are we all good with that? Okay, I'm open to any other ways you've learned to measure this. Okay, humeral rotators. Ideally, you want to, again, you've got to keep the arm elevated off the table. Again, to keep the humeral head approximated in the glenoid. We cannot drop it all the way down. So if you bring it up a little bit, now, ideally for measuring length of rotators, you're taking them out to 90 degrees abduction, measuring external rotation, measuring internal rotation. Okay? Neurologic patient, you're not going to get them out that far, likely. Okay? So just figure out where can you measure them. So typically about 45 degrees is fair. You gotta get them in somewhat of a position that there's no pain, it's comfortable. They're restricted from 0 to 90 all the way up, it doesn't matter. But just try to get a little bit of an open pack position. Measure that angle, usually about 45, then measure your external rotation, right? And the number is really usually 0 to 10, so don't be looking for big numbers. I mean, visually look at it, it's here, you know that's not a very big number, right? So when you put your goniometer up there and you're measuring here, measuring this angle, it's gonna be like 20, okay? Internal rotation is not as likely to be restricted. Here, likely you're going to remember they live here. They're already in internal rotation. That's usually pretty close to normal. Maybe about 60, 65 degrees. You're going to get plenty of internal rotation. The external rotation is what's going to be painful for them and very restricted. So get your infield and get a measurement. The other thing I want you to do with the external rotation is consider if the humeral head is anterior in the socket. How much more external rotation can they get? It's blocking it. Yeah, it gets blocked. So another thing I'd like you to try, and they just call this a positional fault, is recorrect the position when you're over here to measure it, external rotation, come in, give a gentle posterior glide. You'll actually feel the humerus kind of reseat, recheck. If you gain significant range, what does that tell you?